Take off your socks, right now if you can, or as soon as you have finished watching this. Put your bare feet flat on the floor and look at them. After 30 years of clinical observation, I can tell you something that may surprise you. Your feet are the most honest diagnostic tool you own, and almost nobody under 65 has looked at theirs properly in 20 years. The signs of joint collapse, hip weakness, balance decline, and bone strain show up on your feet long before they show up anywhere else, and most of them are visible in less than 60 seconds of careful looking. I am going to walk you through 7 of them today. Before we begin, a quick note. This is educational content, not medical advice. The signs I am about to describe are general education. They do not replace evaluation by your own physical therapist, podiatrist, or physician. If anything I describe causes you concern, please bring it to your own clinical team this week. Dr. James Whitaker is a composite educational character built from 30 years of represented physical therapy experience. If you have had recent foot or ankle surgery, severe osteoporosis, diabetic neuropathy, or significant balance impairment, please work with a hands-on clinician for hands-on assessment of your feet rather than relying on a video. Sign number 1 is the callus pattern. Look at the skin on the bottom of your foot, specifically the ball of the foot just behind the toes. Healthy weight distribution shows light, even thickening across the pad. The patterns to notice are the abnormal ones. A heavy callus directly under the second metatarsal head, which is the bone behind the second toe, often means the big toe has stopped doing its share of the work in propulsion, and the second toe is taking the load. A heavy callus on the outside edge of the heel suggests the foot is rolling outward, which is called supination, and the hip on that side is often weak. A heavy callus across the entire ball of the foot suggests overall fallen arch and excessive forefoot loading. A 2018 paper in the Journal of Foot and Ankle Research, following 220 older adults, found that abnormal plantar callus patterns predicted gait abnormality and falls risk with accuracy comparable to formal gait analysis. Your feet keep a written record. We just have to read it. A small detail on calluses because patients often miss it. The thickness matters less than the location. A man who has worked on his feet for 40 years will have thick skin everywhere on the bottom of his foot, and that is normal and protective. What matters is whether one spot is thicker than the surrounding skin in a way that suggests the load is concentrated there rather than spread across the whole pad. Run your thumb across the bottom of the foot. You can feel the hot spots. Those hot spots are where the bone above is loading the floor more than its neighbors, and that is the diagnostic information. The shoes are also a clue because shoes record the same hot spots from the other side. Sign number 2 is big toe drift, called hallux valgus. Look at your big toe from above. The big toe should track in line with the long bone of the foot behind it, called the first metatarsal. If the tip of your big toe is drifting inward toward your second toe, you have early or established hallux valgus. This is not just a cosmetic problem. The big toe is the engine of propulsion. Every step you take pushes off through the big toe. When the big toe drifts, that push goes sideways instead of straight back, and the knee on that side gets a small torque every step. Multiply by 10,000 steps a day, and the inner knee on that side starts to complain. Case after case I have seen documented for inner knee pain showed a quiet hallux valgus they had not connected to the knee. The connection is real, and the research is consistent. Sign number 3 is fallen arches. Stand up barefoot in front of a mirror, or have someone take a photograph of your feet from behind while you are standing. Look at the inside of the foot, just in front of the heel. A healthy arch shows a clear curve, with daylight visible between the inside of the foot and the floor for at least a couple of inches. A flattened arch shows the foot collapsed against the floor. There is variation in healthy arch height, so a small amount of flattening is normal with age. The concern is asymmetry, or a recent change, or a flattening that comes with new pain. The fallen arch shifts the entire alignment of the leg above it. Knee tracks inward, hip tries to compensate, lower back gets twisted in the bargain. The whole chain follows the foot. Sign number 4 is hammertoes. Look at your toes from above. The smaller toes, 2 through 5, should lie roughly flat against the floor. Hammertoes are toes that have curled into a permanent claw, with the middle joint of the toe bent up and the tip of the toe pointing down. They often develop slowly over years from a combination of tight footwear, weak intrinsic foot muscles, and abnormal pressure patterns. They matter because they reduce the surface area of your foot on the ground, which is the same as reducing your balance. The smaller the contact patch with the floor, the more your hip and your core have to work to keep you upright. People with established hammertoes have measurably worse balance scores in research studies. Let me pause here for a moment. I do not want you to look at your feet and panic. None of these signs is a verdict. They are pieces of information. The point of looking is so that you can do something about what you find. The intrinsic muscles of the foot, the small muscles between the toes and on the underside of the foot, are responsive to training even in adults over 70. A simple toe spread exercise, performed for 2 minutes a day, can improve toe alignment and arch support over a period of months. Talk to your physical therapist or podiatrist if any of these signs are new or asymmetric, and ask whether targeted intrinsic foot strengthening might be part of your plan. There is a simple test for hammertoe severity that you can do at home. Sit on a chair with your bare feet on the floor. Try to lift only your toes off the floor while keeping the ball of the foot down. Then try to spread your toes apart like a fan. Then try to press the pad of each toe individually down into the floor. If you cannot do any of those 3 motions without the whole foot moving, the intrinsic muscles of the foot have gone to sleep. The good news is that those muscles wake up. They wake up slowly. They wake up over months, not weeks, but they wake up. Sign number 5 is uneven shoe wear. Pick up the shoes you have been wearing most this year. Turn them upside down and look at the sole. A healthy adult with reasonable gait shows even wear across the outside edge of the heel and across the front pad, with slight wear on the inside edge of the front pad where the big toe pushes off. The patterns to notice are the asymmetries, one heel worn down to nothing while the other is intact, the outside edge of one shoe destroyed while the inside edge is pristine, the toe end of one shoe scuffed up while the other is clean. These asymmetries are a written record of an asymmetric gait, and an asymmetric gait, sustained over years, is one of the strongest predictors of one-sided joint pain that I encountered in clinic. A 2017 paper in Gait and Posture noted that shoe wear asymmetry was correlated with single-sided knee and hip osteoarthritis development in older adults. Sign number 6 is ankle pronation. Stand barefoot. Look down at your ankle bones from above. The inside ankle bone should be roughly stacked over the inside of the foot, not collapsed inward. If, when you look down, the inside ankle bone is bulging inward and downward, the ankle is pronating, which is a sign of poor support from the small stabilizing muscles around the ankle. Pronation is not a disease. Many feet pronate slightly and function perfectly well. The concern is recent change, asymmetry, or pronation that comes with new knee or hip pain. The ankle is the first joint in the chain from the floor up. Whatever it does, the knee and hip must compensate for. Sign number 7, and this one surprises people the most. Look at your toenails, specifically the thickness, the color, and the shape of the nail on the big toe. A nail that has thickened, yellowed, ridged, or curled at the edges in the absence of fungal infection can sometimes be a sign of chronic microtrauma. The big toe is being repeatedly compressed in shoes that do not allow it to push off properly, or the bone underneath is being loaded abnormally because of gait pattern higher up the chain. Now, there are many other causes of toenail changes, from fungal infection to circulation problems to nutritional issues, and you absolutely must talk to your podiatrist or physician about any nail change you are not sure about. But mechanical microtrauma is one cause that gets missed, and it is the one that responds to gait correction and footwear change. Let me pause again. 7 signs: calluses, big toe drift, fallen arches, hammertoes, shoe wear, ankle pronation, toenail change. That is the list. You do not need to memorize it. You need to look. Tonight, before bed, take off your shoes and your socks. Sit down somewhere with good light and look at your feet for 2 full minutes. Then look at the soles of the shoes you wore today. That is the assignment. There is a piece of research worth knowing before we move to the patient stories. A 2019 study published in the British Journal of Sports Medicine, looking at over 1,000 older adults, found that a simple at-home foot assessment, similar in spirit to the one I have just described, predicted falls within the next 12 months at roughly the same rate as a 30-minute formal balance assessment in a clinic. Same predictive value. 20 minutes of self-observation against 30 minutes of professional testing. The feet are that rich a source of information. 2 composite patients before we close. The first composite case is documented as Vivian, 74, a retired librarian whose left knee that had been hurting for 2 years. Her left big toe had drifted noticeably toward the second toe over the same period, and the callus pattern on her left forefoot was twice as thick as on her right. The documented protocol did not address the knee first. It addressed the foot. 6 weeks of intrinsic foot strengthening and a footwear change, and the knee pain began to settle. The knee never needed direct treatment. The knee was always the foot's downstream complaint. The second composite case is documented as Theodore, 78, a retired postman who had walked an estimated 30,000 miles in his working life. Theodore had hammertoes on both feet, and his balance had quietly deteriorated over 5 years. His daughter had started worrying about him on stairs. The documented intervention worked on toe alignment with toe spread exercises, toe yoga as some clinicians call it, plus single leg balance work appropriate for his level. 3 months later, his single-leg balance time had doubled, and his daughter stopped worrying about the stairs. Case after case I have seen documented for balance decline turned out to have a foot problem first and a balance problem second. Here is the question to bring to your next podiatrist or physical therapist appointment. Tell them, I would like you to assess my feet for the 7 signs of joint collapse, and tell me which ones apply to me. That is the question. It will get you a structured assessment in 20 minutes. Bring this protocol with you. Talk to your physical therapist or physician. The decision about what to do next is yours and theirs together. If you do nothing else from this video, look at your feet tonight. Just look. Tell me in the comments which of the 7 signs you noticed for the first time. I read every single comment, and the patterns I learn from your replies inform what I teach in the next video. A short word about footwear because someone will ask in the comments. The single biggest footwear mistake observed across 30 years of clinical work is the slipper. Patients spent 8 or 10 hours a day in soft, structureless slippers indoors, and the small muscles of the foot adapted to having no work to do. Then they put on a shoe to go outside, and the foot was unable to support itself in the new environment. If you spend a lot of time in slippers, that is not necessarily wrong, but consider spending part of your day barefoot on safe surfaces at home, so the foot has to work. The foot is a muscular structure. It needs occasional honest work to stay strong, just like every other muscle group in the body. The second footwear note is on toe room. A shoe should have at least a thumb's width of space between the longest toe and the front of the shoe, and the toe box should be wide enough that you can wiggle all 5 toes freely. Decades of narrow toe boxes are part of why hallux, valgus, and hammertoes are so common. The foot follows the shape it is held in for years. Until next time, move well, stay strong, and remember that the answer to a knee problem is often hiding inside your sock. Take care of your feet. Take care of the people who love you, and keep walking on your own. One last thought. If you have a partner or a family member at home, ask them to look at your feet with you tonight. A second pair of eyes notices things you will not. They will see asymmetries you have stopped noticing. They will spot a callus pattern you have lived with for 10 years. It is also a small, quiet way of letting someone close to you know that you care about staying on your own feet for as long as you possibly can. That conversation is part of the work, and it costs nothing at all. The feet are honest. Listen to what they are telling you, and bring what they say into your next appointment with someone qualified who can help you act on what your feet are telling you today.